Hi, everybody. My name is Andrei Naeymi-Rad. I'm the VP of Corporate Strategy with a company called Intelligent Medical Objects. We provide foundational content and data quality services for healthcare. And today, I'm going to be talking about why open source data fails AI in healthcare. A little while ago, our company did a query on a few stakeholders in the industry, and we wanted to talk about, what was really challenges that you as an organization were having. And 45% of them said, I had major data challenges in my organization. These are large IDNs, all the way to mom and pop doc shops, and it was a major threat to my organization. And we wanted to double click on that a little bit more. How much of it was a financial impact to your group, and did it have actually poor data affect financial impact? And 90% of those organizations said that they had a major financial impact in their group. And so today, when we think about, well, what challenges and what solutions are you looking for to help address that? Data quality and data quality services are areas that organizations are looking at. And there's major reasons why these are problematic in the industry. We all know code sets change, and they change on a quite often basis. And a lot of groups will use open source terminology standards like UMLS or like OMOP to achieve these kinds of minimum viable goals, but it puts it back on the shoulders of the customers to keep up to date. And here's a couple of examples of some standard code sets that HTI2 and USCDI and other different reference data operations deal with on a daily basis. But for you as organizations that need to keep this content up to date, that's back on you as a shoulder to manage and maintain this. So today we're going to go through a story here about using a term that's used in endocrinology about what impact do using these code sets reflect in understanding the accuracy, the true accuracy of what's going on with the patient population. So if I'm using an open source terminology like UMLS, I probably am using synonymy architectures, or I'm using an LLM that's using synonymy. So for any one of us that are here, if I use an acronym like MI, that probably means myocardial infarction, right? But if I'm a pediatrician, MI can also mean mitral incompetence. So understanding context, if I'm just using an open source reference library operation to be the backbone of my data operations, this is a good example of where acronyms, eponyms, abbreviations will break that architecture and break it quite often. Similarly, when there is no term for a synonymous architecture like mammography screening for both breasts, if the terminology doesn't have it, you're left in the dust to try to figure out what's the best way to manage and maintain this information. These are challenges that we all deal with on a regular basis, yet we still use open source terminology operations to help manage and maintain the standards around us. So if I'm using a benchmark like a billing or a financial impact, ICD-10 is what we use on the diagnosis, problems, and symptom space for diagnosing, right? So if I use ICD-10, I'm going to break ICD-10 down here for this kind of statement: type 2 diabetes with stage 3B chronic kidney disease and long-term current use of insulin. To any endocrinologist, that is a clinical statement. But if I'm using ICD-10, there is no one statement that reflects that. So if I highlight a couple of different terms that are in here using ICD-10's nomenclature, and I wanted to code that statement appropriately, I actually miscode and undercode the true understanding of what's going on here. Now, you could probably say, hey, Andre, I'm pretty good. My LLM actually does this pretty well. And, I actually noticed here, Andre, that you didn't identify stage 3B chronic kidney disease. Well, that's fine. Let's find it, right? ICD-10 does have a term for that. But you're still missing that DM2, when taken into the consideration of the entirety of that statement is understood, that is actually an incorrectly mapped statement when you just use ICD-10. You're missing the chronicity, you're missing the greater specificity of that information set. The only way to truly understand the full statement at scale is to make sure you're taking the entirety of the statement as an understanding. So this is really, really important when you get into ambient documentation or understanding complex clinical conditions in multiple different areas of a statement. You have to understand it at this kind of capability. So let's flip that on its head a little bit, right? If I'm dealing with USCDI compliance and I'm trying to write that data back into the EMR, I cannot only just talk ICD-10. I have to talk other languages. So SNOMED is a great terminology operation that is used in a post-coordinated way, another open source terminology, and you can string those terms together, and SNOMED has some great crosswalks. Unfortunately, if I start with SNOMED and I use the crosswalks for this statement, I'm still getting a miscoded and undercoded representation of that patient population. But Andre, again, like I have a great LLM. I can find that stage 3 chronic kidney disease with SNOMED. That's great. But still, you're missing a crosswalk problem here that doesn't get to the right level of specificity that's required for that statement. And even if you did take the entirety of that statement in place and you post-coordinated that expression appropriately in SNOMED, SNOMED's crosswalk operations and UMLS's crosswalks operations still have a problem where you have to still select one of these ICD-10 codes. And that's a data governance and data fidelity problem that large institutions and organizations have when you're trying to better understand the chronicity of your patient population. And so if organizations have a lot of, sorry team, if organizations have a lot of problems understanding the data quality of the underlying data, they know it's a data quality problem, but they still use open source standards. These are data operations that are still problematic for groups and areas that are going to be continuing to be a challenge going forward too. Now, you might say, hey, Andre, I found an ICD-10 code. I found a SNOMED code. I don't care if it's right. I'm in the ballpark and it's good enough. Well, as we all know, good enough is not good in healthcare. That has a direct financial impact on billing and revenue. And just like we talked about here, if I was trying, and my target code set was ICD-10, and that is a billing and financial impact operation, in that one statement, we actually went through multiple different stories where you're still getting a miscoded and undercoded representation of that data. And if I'm getting a miscoded and undercoded representation of that data, that's also going to have a direct impact on my care prioritization. If I'm not understanding my high-risk patients, I don't know where to send my optimization for my patient care, right? And furthermore, if I'm looking at this at a population level, I'm actually not understanding my chronic patients appropriately either. So then you're probably saying, all right, well, I know CDI takes this on. I know my population group might take this on. That's great. But still, we walked through a bunch of stories here where that underlying data quality issue is still problematic. Now, if I move into an area that might be a revenue generating operation for my organization, it might be a research collaboration. But if I'm using open source terminology operations to help qualify and quantify my patient population, that's actually incredibly inefficient. And I'm throwing bodies at the problems to help deal with the data quality inequity that's happening from those research collaborations. Similarly, if I have an EMR that's using a clinical terminology like IMO, and I'm trying to use an open source terminology as a separate software application, and I want to communicate that data back into the EMR, if I'm not using the same language and I'm using a crosswalk language, I'm actually miscoding and undercoding the writing back into the EMR. So organizations have a really large challenge buying into different software applications that need to write back into the EMR if they're not speaking the same language. And that feels like a disconnected environment for them. And if you're using open source terminologies, these are the problems that will always happen within organizations. But furthermore, all of this boils down to patient safety. If you're not coding data appropriately at the front end and you're using crosswalks and you're undercoding and miscoding your patient populations, you're actually not providing the correct treatment protocols for your patients directly. And that can have an impact on decision support triggers. If I'm Elsevier or UpToDate and I want to make sure I'm going down the correct care pathways, I need to make sure that my trigger protocols are actually written appropriately behind the scenes. And if I'm not using the correct coding language to define my patient population, I'm going to go down a completely different care pathway for that. Similarly, if I go from one organization to another organization and I have miscoded or undercoded representation during that interoperable state, I'm actually moving incorrect patient specificity to that area. We all know these are challenges, but still we lean back on the open source terminology services that are out there to fill in these gaps because we feel like it's good enough. But these are problems of why it's not good enough. Now, we've done tests internally at IMO, and when we look at terminology standardization across populations, how often is UMLS truly understanding my chronic patient populations in the industry? And for 80% of your market, you're probably going to be good enough, right? I'm dealing with urgent care. I'm dealing with outpatient care, right? That's not really that chronic conditions. But for your 20 or 30% of your population that represents 80% of the cost of care, using these open source terminologies actually does not get me good enough for those care protocols. And we've done these studies across millions of different publications that are out there, millions of different terms that are out there to find out, like, is this truly representative of what's going out by patient? And it's not. Open source terminology does not hit the mark for the vast majority of your high risk, high cost patient population. And don't take my word on it. This is a 200 doc practice in Northern Illinois that used a open source terminology data operation in the aggregate space to run reports on their data quality and their electronic clinical quality measures. Orange was what was coded. Green, or the blue, is actually what should have been coded had they actually pulled that data down appropriately with the right level of specificity, like a company like IMO does on a regular basis. So don't take my word on it. There's a lot of logos that use IMO's terminology on a regular basis. If these are challenges that you're dealing with as well, please come to our booth. Our booth is 2225, I'm sorry. And we're here and we'd love to talk about it. But here's some great data aggregator vendors like health information exchanges or on-demand analytics vendors that have saw this challenge and wanted to address it right at the direct use cases. And our team is here more than happy to help provide better value to that data inequity that you're probably seeing in the data quality space. Thank you all so much.